So thank you all for coming tonight to Healthcare Reform. I'm Amy Scott, the Program Services Coordinator for the Fort Vancouver Regional Library District. And I'd like to welcome again the League of Women Voters of Clark County and thank them for presenting tonight. Just as we're getting started, I'll just tell you, please keep your microphones muted except when you're speaking. And remember that this is a library program, so the library rules of conduct do apply here just as they would if you were in the library. I'll be keeping an eye out for any kind of issues like someone's walking around in the background. I can turn off your video just for privacy. I can mute your microphone if you forget to turn off, so you can not worry about those kinds of things. And so I think that's all we have in terms of housekeeping issues. So I'd like to introduce Heather Beecher from the League to start us off this evening.
Hello, I'd like to start with a land acknowledgement. We collectively acknowledge this gathering as being held on the stolen and unceded ancestral land and contemporary lands of the Chinookan people and the Cowlitz Indian tribe. We pay our respect and gratitude to the indigenous peoples of this land, past, present, and future. With this acknowledgement, we commit ourselves to continued education, accountability, and social justice. And then I'd like to introduce two League members who are going to do the presentation, Alan Unell and Voki Hogagimian.
Thanks very much, Heather. I really appreciate it. I'd like to acknowledge Heather Beecher and Voki Hogagimian, my wife, who actually helped put this presentation together. I'd also like to thank the League of Women Voters for allowing us to present it here. I would like to point out that this is an educational presentation. It's not one side or the other or any particular side. It is, here's what's available in healthcare reform and why we might want to consider healthcare reform as a thing to spend our time thinking about. So let me share my screen. Anytime you have questions, I would like you, if it's at all possible, put them in the chat, and periodically we're going to stop and ask for questions. And if we're not getting to you fast enough, I think you can probably unmute yourself and ask your question, and we will take care of it to the best of our ability. If we don't, I will point out, if we don't have an answer for your question, we'll get back to you with the answer. At the bottom here, you should see our emails, alanunell@gmail.com and vokui@gmail.com. And any questions you have or any way you want to communicate about healthcare reform, we're delighted to talk to you about it. Again, this is a League of Women Voters presentation. Let's advance slides. And the League, let's remember, the League of Women Voters, their tagline is "Making Democracy Work." We are a nonpartisan political organization. We encourage informed and active participation in government, and we influence public policy through education and advocacy. And tonight's one of those education nights. Okay, so let me tell you what the League position is. This is the League of Women Voters nationally. What the League's position is on healthcare. And this is not new. This comes from the 1990s, and there's a link at the bottom there. You can go and get their document and read it. The League of Women Voters of the United States believes that a basic level of quality health care at an affordable cost should be available to all U.S. residents. Other U.S. healthcare policy goals should include the equitable distribution of services, efficient and economical delivery of care, advancement of medical research and technology, and a reasonable total national expenditure level for healthcare. The League favors a national health insurance plan financed through general taxes in place of individual insurance premiums. And that's documented in their impact on issues. So here's what we're going to talk about today. We're going to talk about the history of healthcare. We're going to talk about a worldwide history of healthcare. We're going to talk about healthcare funding mechanisms because it is not free. And there's a crisis of healthcare in the US, and it's partly related to diversity. And we'll discuss that. Actually, the diversity part will show up in several locations in the presentation. We're going to talk about how people put together systems of healthcare in the United States and which ones we have and how come it looks the way it does. We're going to talk about what national legislative initiatives are in front of us. These are pieces of legislation that have been introduced and are under discussion at both the national and the state level. And then there are tons of references for you to learn more later in the presentation. So let's start with some definitions, because it works well when we all, whoops, don't do that, when we all talk the same language. Universal health care means everyone has access to health care. If the funding model is insurance-based, for instance, it means that everybody gets insurance. What does everyone mean? Well, we need to address that when you design a healthcare system. Some countries include just citizens, some include anybody that's legally present, even tourists, and some people include all of the above together with people that are not documented. It's part of however you define your system. Let's advance. So the history of healthcare. Where does it start? In 1889 or so, Bismarck put together a health insurance program in Germany. It was the beginning of universal health care. It didn't cover everybody. It covered about 10% of the population. And the people that were covered were industrial workers. And the reason they needed to be covered was they learned a skill working in industry, in a factory. If they get hurt, you want them to be able to come back to the job and continue working. And the model they put together, we'll discuss it a little more later, is really private mutual insurance companies that provided both healthcare and sick leave and disability payments. So it's a little bit broader than just healthcare. In 1911 in the UK, they pretty much did the same thing for, it says employees, but it's industrial employees, it's factory workers. In Italy, guaranteed hospital care was put in place for everybody. You may be getting the flavor. The problem with the cost in early medicine in the early 1900s was not so much the doctor, it was the hospital that was expensive. So in Italy, put it together in 1978, and they actually established universal health care in 1978. In the 20s, they put their basic healthcare hospital plan in place. Japan followed suit for mandating healthcare for industrial workers in the 20s in 1922. By 1958, everyone had health insurance. 1938, New Zealand established health insurance for everyone. In 1947, Saskatchewan, which is like the Wild West in Canada, decided they would introduce universal hospital care, just hospital care. It became incredibly popular, and by 1984, all the provinces and all the provinces in Canada had a similar plan, all working together. They all cooperate together for both healthcare and for hospital care and doctor care. In the 70s in Western Europe, there was a major restructuring of healthcare to include more and more people. In the 80s, there was a third wave of healthcare reform in Western and Eastern Europe. This is, remember, the time where the Berlin Wall is coming down. They did have to put through cost containment measures, and of course, the fall of communism allowed this to spread into Eastern Europe as well. In the 1990s, the Maastricht Treaty came into being, which created the European Union. And so they needed to make sure that there was healthcare available for all the member countries, and that as you move from country to country, you would be cared for. In 1995, Taiwan established universal healthcare, but they did it in what's called a single payer kind of system, where the country, the government, becomes the insurer. And we'll talk a little bit later about some of the benefits they got for that. Well, I'll mention one of them. In the midst of the pandemic, since they knew where everyone was, they could do contact tracing incredibly well. And in all of 2020, the total number of COVID deaths in Taiwan was 200. So they had a public health benefit because of that. Let's see. Taiwan. So let's talk about the history of healthcare in the US. Well, the US was following along pretty well. President Theodore Roosevelt wanted universal health care for industrial workers in 1910. He was not able to get that in place. In the 40s, I'll be frank, I'm old, but I don't remember it. But in the 40s, there was a wage freeze because of World War II. So companies were not allowed to raise wages, but they needed to attract and maintain workers in place. And one of the ways that they were able to do that was by providing health care. This is just about the same time that a young doctor, I think in Nevada, got the idea of prepaid health care, which he sold to what became Kaiser Permanente. And the Kaiser engineering firm picked it up to keep people in the shipyards working. Actually, we had that here in Vancouver in 1941. In 1948, President Truman proposed wide-ranging social change. Initially, he wanted to put together Social Security and universal health care for everybody. This is part of the DEI portion of the lecture. The American Medical Association sought to quash is the word, universal health care because they did not want to force doctors to treat anybody that walked in the door. You can read that as they didn't want doctors in the South to have to treat Black people, because that's what it was. In 1965, Medicare was established in the US. Part of the problem we had there was that once you retired from your job, you pretty much didn't have health care, health insurance. And because of that, older people were not able to get all of the medical care they needed. And bankruptcy was a real thing for people in their 60s. It was not good. One of the items that Medicare doesn't get a lot of credit for, though, is on the DEI front in social justice. Once Medicare was established, hospitals throughout the United States became integrated. Segregation in hospitals went away, which is a real big deal, but they don't get credit for it. Let's move on. So in 1995, the United States, seeing that Europe put together universal health care for pretty much everybody in the European Union, it's pretty much all 35 of our industrial competitors had it. The US tried to do it and failed. I would point out that as the US was trying to do it, Switzerland did, and they were actually able to put it in place at the same time. I'll talk about their system a little bit later. In 1997, Medicare Part C was established. Now there are pluses and minuses. You may not be familiar. Part C is called Medicare Advantage, and it looks very much like mostly an HMO, a health maintenance organization, a prepaid medical scheme. Some of them are PPOs, preferred providers, but most are HMOs. That was established in 1997, where the US government shared some of the healthcare risk with private insurers. It has ballooned to the point where about 1/3 of Medicare participants make use of it. And those companies that picked it up actually do quite well for themselves. They make quite a bit of money. CMS, who runs Medicare, actually pays them quite a bit to manage those policies. In 2007, Part D, you may not know it by its nickname, but Part D was the Medicare drug plan, was established. Now, I don't include the information here, but this doesn't sound nice, but this was kind of a giveaway to the pharmacy companies. It includes verbiage in national law that prohibits Medicare from negotiating prescription drug prices to the benefit of subscribers. So it's pretty much, you pay what you have to pay. Excuse me. We'll talk again about that a little bit later. In 2009, the Affordable Care Act was enacted in the United States, which was not a bad scheme, although it involved private insurance companies to pick up the risk and sell policies to people and everybody had to have a policy. And if you couldn't afford one, the government would help you pay for one. It's one way to go to get people covered. Remember, there are many ways to solve this problem. In 2010, means testing for Medicare Part B was enacted. Again, you may not know it by its nickname, but Part B is the Medicare that pays for the doctor and tests and things like that. Previously, everybody paid the same amount. Now it depends on what your income is, how much you pay. In 2017, the Affordable Care Act mandate to have insurance was removed, thus weakening the plan dramatically. And so it no longer functioned as any kind of an insurance risk pool. Part of the side effects of that, one of the things that was implemented with that, was that catastrophic policies became more widespread and increased the number of uninsured. What does that mean? Well, I don't know. When I graduated college, I had the ability to go pick up a catastrophic policy, and it was like a $15,000 or $20,000 deductible. So if something horrible happened to me, then I would be able to have this as additional insurance. People that have those policies typically don't go to the doctor unless they absolutely have to, because they're going to pay for everything until that first $15,000 or $20,000 is covered. Okay, so that's kind of what the history of it is. There's a question. I should read the question.
Yeah.
It says, from Irene, thank you. I read on a site this week that CMS Medicare does not provide oversight of the Part C insurance companies. I wonder who provides the oversight for the quality of care from these health insurance companies.
No one. Pretty much.
That's a good question. I'm going to table that for a minute, if that's okay, Irene. It's a good question because CMS does provide for quality measures of CHIP and Medicare and Medicaid. You are correct about that. And for Medicare, when it's not handled through a separate insurance company. Okay. Oh, we have a little bit more of the history of healthcare. I apologize. In 2000, the World Health Organization Health for All strategy was put in place to spur reforms in healthcare for Europe and other developed countries. And the UN member states have agreed in 2020 to work towards universal healthcare coverage to be implemented by 2030. So that's the goal. Now, let me show you where we have universal healthcare and where we don't, and where people get covered and they don't. Now, this map is a little bit hard to read. You can see there's a Mirror Kitty put this together on Wikimedia, but I'm very grateful for that. The green, I don't know if you can see my cursor, but this color green here is free and universal healthcare. What that typically means is, when I say free, is that it's covered in some way. It's generally taxes of some sort that pay for it. The light green color is universal healthcare, and there's not too many. I think if you looked at, that might be Ghana, I'm not sure. Free but not universal are the blue colors. Oh, I don't know who that is in Central America. I'm just embarrassing myself. India, I know India is, who is this? Is this Mongolia?
Yeah.
Mongolia. They have free care, but not universal. So what does that mean? As an example, in India, there is free health care if you're a government employee. If you're not, it's pay as you go. You just pay. I think there are a couple of countries, there are 204 countries, I think, in the world, and there are a couple of them here that are gray, and it means they're undetermined what their healthcare strategy is. Red countries, like the US and some others, there's only about a dozen, have no free or universal healthcare. And that's just where we are. So, okay, that's interesting. How do people pay for healthcare? Well, there are a lot of different techniques. So let's talk about them. So we, again, have the same footing. So Canada, Denmark, Norway, Sweden, they're all examples of health insurance. Taiwan, that's another one. Oh no, Canada, Denmark, Norway, Sweden, they have health insurance that's publicly administered, and most physicians are in private practice. Yeah, that's actually similar to Taiwan as well. That's a single payer kind of system. And that kind of works where there's an insurance trust that the government sets up, and people, providers, submit claims to the insurance trust and then get paid. Some countries like Great Britain and Spain have a national health service. What that means is most of the physicians are salaried, sometimes with bonuses, and most of the hospitals and facilities are publicly owned and operated. They usually, regions in Great Britain will have hospital trusts, but they're public. Universal insurance is highly regulated, universal, that means everybody, multi-payer health insurance systems. They're used in Germany and France are examples of those. Germany has hundreds of sickness funds that take care of this. France, it's done at the state level, and the state maintains those sickness funds or those local insurance systems. In France, it's sort of interesting. You could have to pay into the French system if you're a visitor. However, most of the system is supported through the federal government and the state governments. Now, then there are private systems. Now, a mandated private system, remember I told you about Switzerland a little while ago? In Switzerland, what they did, the same time the US was trying to put healthcare reform in place, I found it very attractive because in Switzerland, they speak a bunch of different languages, like 4. And they were presented with a situation where people were going bankrupt from paying for, not being able to pay for healthcare. And a lot of people didn't get the healthcare they needed and were dying. And they looked around, they said, you know what? We speak 4 different languages, but we're Swiss. We're all Swiss. We're not going to let this happen. And they created their own system. Essentially, their system is private insurance companies sell a mandated basic healthcare policy, which everybody buys, at no profit. It's sold at no profit. You can't make any money on that. However, you may want to purchase additional coverage for things like a private room or those knee replacements or plastic surgery, and people purchase supplemental care. It's worth mentioning, though, that many of the countries that have some kind of universal care do offer, private companies will offer supplemental care, generally for things like hearing aids, vision, dental, that kind of stuff. Non-mandated care, that's what the US has. Most coverage in the US is cost shared with employers. It's about half of the people here go with private insurance companies through their employer. There is not really a minimum basic preventive level in place because the catastrophic policies took so many people out of the ACA. And of course, there are other countries that have pay as you go, like India. If you have enough money, you can get to see the doctor. So let's advance. Excuse me. Ooh. So here's a question, a bunch of questions. We were going to have a poll, but it's too hard. So here, how good is your insurance? A lot of times people are not interested in changing health insurance schemes or models because they say my policy is fine. Why should I change it? Here's a question. You can ask your insurer this. Is emergency hospitalization covered? If I get knocked unconscious and can't choose where to go, and somebody takes me to a hospital that's not in my plan, what happens to me? It's good to, the answer is not always a good answer, but you should ask. Can you get a second opinion? Will your insurance cover a second opinion? Can you go see a university specialist? Can you see any provider? Find out. You should know these things. Excuse me, I will tell you, I have a brother-in-law who at the age of 25 had thyroid cancer. And he went to Kaiser and he said, I got a sore throat all the time. Something's wrong. And they said, take cough drops. And so he said, that's not the answer. So he went to see a thyroid specialist. The guy said, oh my God, you've got thyroid cancer. How'd you get this? And he wrote up the report for $2,000 and sent it back to Kaiser. Kaiser didn't reimburse him, but they did take care of the cancer. That was good, but he had to pay for that second opinion. Mental health coverage. Do you get any in your insurance? Do you get counseling coverage? How much is enough? The answer is not, it's usually not very much, but you should find out. How about emergency transportation? Is that covered? Is your ambulance ride covered? What if they have to take you in a helicopter? Is that covered? I heard recently from some people up in Seattle, way north of Seattle, that that's not an uncommon thing up there. And what they were telling me was it's $10,000. It wasn't on their policy. They were very upset about it. How about drug prices, with and without your insurance? Okay, it says it's a trick question, but I'm going to give you the answer. This is a really long story and not really suitable for this presentation, but pharmacy benefit managers kind of control your copays in insurance. And it's when you go to the pharmacy to get a prescription filled, if you have insurance, your pharmacist is usually precluded by a contract with pharmacy benefit managers from offering you anything cheaper than the copay. Ask them, is there any way to get this cheaper than my copay? They've got to tell you, but they don't tell you unless you ask. And I'll give you an example. I take, well, actually my wife takes some medicines. It's way cheaper for us to get them on GoodRx than it is to go through insurance. That's just one of the ways to get lower prices. Costco has their own system. Here's one, occupational and physical therapy. Is it enough for restoration for you? What if you're slow to repair? Do you have to pay for physical therapy instead of your insurance? The answer is your policy might be really good and you're just good with this stuff, but for lots of people it isn't. Let's move on. So what's the healthcare crisis in the United States? Here's the problem we've got. And most of these data are pre-pandemic. So in the United States, about 33 million people don't have health insurance. That's pre-pandemic in 2019. And about 41 million people are underinsured. This is according to the Commonwealth Fund in 2020. Underinsured means you have a high deductible policy. That's ages 19 to 64. About 1 million people every year in the United States file bankruptcy as the result of medical expenses. That typically, what that does is that increases the cost of healthcare to everybody. I'm just pointing that out. According to the Consumer Fraud Protection Bureau, a branch of the government, about 15.3% of people in the United States have medical debt that's in collection. So you're more than 90 days overdue. GoFundMe.com, I don't know if you guys ever look at that website. They have annually about 250,000 campaigns to raise money only to pay healthcare bills. This is in 2021. They raise about $650 million yearly to pay people's healthcare. There are a lot of problems. Rising premiums, deductibles, copays tend to limit, people do that in order to limit the costs of healthcare. You know, if they risk share with you, maybe you won't use the insurance quite as much. Well, the Rand Corporation down in Santa Monica, California, they didn't do a study. They did an experiment with real insurance policies. And they found that if you increase a copay by 2%, you reduce the amount that people use healthcare by 10%. This is a real thing. This is real human behavior. On the death side, because we should talk about death in the population, according to the Organization for Economic Cooperation and Development, there are about 258 preventable deaths out of every 100,000 people in the United States. These are people that should have had treatment, could have had treatment, didn't go to treatment, didn't get the treatment they needed. All preventable. They don't have to die, but they do every year, often because they don't have coverage or don't make use of it. What other problems do we have in healthcare in the US? Well, you know, businesses are heavily involved in healthcare. They like to put a policy in place for employees. It helps keep the employees there, keeps the employees working and healthy. But premiums and deductibles and copays keep going up. You know, a lot of the people who can't pay for healthcare help raise those. There are other reasons that costs go up as well, but too numerous to mention here. Some regions of the country, businesses don't have any choice from whom to get their health insurance. Eastern Oregon has that in some counties, right and left. And it's a sad thing because insurance, you know, when companies go to buy insurance for their employees, it's 15 to 18% of payroll. That's an awful lot of money. About half, I think it's 45 to 49% of the people who have health insurance get it from their employers. Now, I don't know about you, but I've seen this, where employees will stay in the job just to keep that insurance going. They have a kid that's sick, they have some sort of chronic thing. They can't afford to stop working and go find something else. They've got to keep insurance in place. Unions, this one actually surprised me quite a bit. They wind up spending a lot of time talking to employers, negotiating health benefits, because remember, copays are going up, benefits are going down, and they spend an awful lot of time trying to keep the health insurance benefits secured. They don't get as much time as they would like to actually negotiate other benefits and even wages. So that's not good. That's not good for business, not good for unions. Anyway, here's some of the trends that we have in healthcare in the United States. And you can see this comes from the US Department of Health and Human Services. Pregnancy-related mortality by race and ethnicity. It's a little hard to read here. It's on the charts that you were sent. We have a DEI issue in the United States. I don't have the cause. I'm not that kind of doctor. But take a look at this. These are women who are dying within a year of giving birth per 100,000.
Mm-hmm.
Yeah, per 100,000 live births. 28.3 Native American women die. 41.7, actually it's gone down a little bit. I think in 2020 it went down to 38, but it's still non-Hispanic Black deaths are almost 40 per 100,000. Non-Hispanic white 13.4. I would point out here, infant maternal mortality has increased dramatically. You can see where people started measuring it in 1987, and we were at about 8 per 100,000, and now we're at about 17 per 100,000 for the whole population. You have to take that with the smallest grain of salt. Right around here in 1987, there wasn't uniform reporting of maternal death, but we have it now, and we are not good. Anyway, so that's a problem. Infant mortality is also a problem in the United States. You know, you wouldn't think that it would be. We have hospitals everywhere, but it is a problem. US infant mortality, here are the numbers. This is per 1,000 live births. 4.5, there are 4.63 white deaths, 10.75 Black, 8.15 Native American deaths per 1,000 live births. Take a look at our competitors, our industrial competitors. They're in the 3s. It's not good. How about cost? As a percentage of GDP, this of course doesn't have the latest numbers. As a percent of GDP, we're number 1. This is not the place you want to be number 1. About 17% of GDP. Our industrial competitors, they're in the 7.5 to 12. And the highest one up here is Sweden. Sweden's over. Switzerland. Where's Switzerland? Yeah, it is Switzerland right here. Thanks, Volky. And remember, they're the ones that put the private insurance scheme in place. But even them, they're lower than we are. So that's not so good. How about total per capita spending? This is again from, I think, the Commonwealth Fund. We spend more per person on healthcare than our industrial competitors. And here's just a sampling of them. OECD states, that's our industrial competitors. Average the last digits didn't come out here, but it's about $4,000 per person. We're at over 10,000. And if you read this correctly, the orange is private spending. So the light, how did I do that? Out-of-pocket spending is dark blue. The overall universal or insurance spending is light blue, and then private spending is this stuff.
That's your copays.
Yeah, that's copays, and there's a name for the part of the bill you have to pay that's beyond what insurance covers. I can't think of what that's called, but that's that kind of thing. Okay, how about life expectancy at birth? How long you plan to live? Well, the US, we're at about, when this was done, 2017, we were at about 77. Other countries, Switzerland is the best, they're at about 83.6. Bad news. Life expectancy numbers came out. I didn't get it into the chart in time, but it came out and we've dropped about 3 years. We're not doing good. Between 1 and 3, I think. It depends on ethnicity. We're not doing good. It went down due to COVID, of course. Okay, so what kind of systems do we have in the United States? Other countries, I told you, they have mutual trusts, they have private insurance things, they have private insurance covering everybody. All different ways to do it depending on culture. National health services like in England and Spain. We have everything here in the United States. No kidding, we have a melange of everything. The VA is very much like the national health care in England. It's a hospital that's owned by the system and the providers are pretty much employed by the system. We have Medicare. Outside of Medicare Advantage, Medicare is a public insurance. It pays private providers in it. It's kind of similar to what France and Germany have, except it's or Taiwan, except it's a single system. We have Medicaid and CHIP, which are mostly federally funded system. They're mostly federally funded, but they're implemented at the state level, excuse me, 50 different ways. It is a giant experiment in the United States how to implement healthcare because every state does it differently. Some of them have HMOs, some of them have PPOs, some of them, those HMOs and PPO, it's not any HMO and PPO, it's the ones they've chosen. And states look at this stuff very hard. They look at their CHIP data, especially, that's the childhood healthcare and infant healthcare. They look at that stuff to see, are children getting seen by doctors? And there are states like, I think it was Vermont, they switched their Medicaid and CHIP methodology several times in the last 10 years in order to get the numbers up on kids going to doctors. So people do look at this stuff pretty carefully. Private insurance is what we have in the United States for more than half, for about half of us. Here's a shocker. I didn't know this. There are 952 separate insurance companies in the United States selling healthcare, selling health insurance. I had the vaguest notion. That is incredible. So private insurance for many providers, networks can be a big issue, HMOs can be a big issue, and PPOs. Includes lots of employer plans, the ACA and Medicare Advantage. Oh, there's my dog snoring again. And then pay as you go, where the ACA mandate is removed. Remember, we got about 74 million people who've got a problem that they don't have. They're uninsured or underinsured. And that's a real issue in the US. So let's move on. What can be done about it? How did we get here? Well, remember I told you in the early 1900s, doctors were not too expensive. People could go to the doctor and pay it out of pocket. I'm old enough to remember my father paying the doctor in cash. I mean, when I was a kid. In 1910, Blue Cross was a nonprofit insurance company, was formed to cover hospitalization. They actually used to send people around door to door collecting 10 cents from people every week from their paychecks. That's about the time when Europe also began to cover hospitalization. In 1915 to 1920, the first major political movement to make universal healthcare a reality in the US came before Congress. And there was a statistician named Friedrich, I can't remember the L, Friedrich Hoffman.
Hoffman.
Yeah, he actually came from Germany. He married a Southern belle, and he wrote a book called Facts and Fallacies. Oh no, Facts and Fallacies of Compulsory
Yeah, there it
Compulsory
is.
Healthcare. He wrote another book about that described how, this is part of the DEI lecture again, how African Americans were more likely to die early and had poorer health overall. He wrote that book in 1889. He wound up as a vice president of, I think it was it MetLife? One of the insurance companies. And they used his book to fight back against a law in New York that said that life insurance had to be offered to all races on an equal footing, same cost for the same product. And I think it was MetLife wanted to cut 1/3 of the premium. No, MetLife wanted to cut, I believe it was them, wanted to cut 1/3 of the benefit for Black people. And they used that as evidence to work against the law. In the 40s, healthcare was provided to industrial workers to support the war effort. Pay raises were illegal, but here's a side note, premiums were deductible for employers. I'll get to that in a minute. In the 50s, in 1948, as I mentioned previously, Truman proposed universal health care for everybody. The AMA and the Dixiecrats opposed it, and it died. In the 50s, President Eisenhower reformed the Internal Revenue Service. What does that have to do with this? He maintained the part of the legislation that kept healthcare premiums deductible for employers. And so that was a strong incentive for employers to offer healthcare because they could do it at lower cost than people could buy it. Because if you and I buy health insurance, it's generally not deductible. But if companies buy it, it is. In 1968, Johnson signed Medicare into law, ensuring the elderly and the retired who generally had no coverage could get it. And it, as I mentioned, desegregated the hospitals. I think the law was put into place, was suggested in 65 is what I had earlier, and signed in 68. Medicare was modified later to include disabled persons and end-stage renal disease. Again, the ACA, Medicare including a means test, and the ACA mandates being removed. We discussed those previously.
Just go there.
Hundreds of pieces, pardon? Hundreds, it's kind of a patchwork. As problems arise, people address them. Hundreds of pieces of, I didn't know this, hundreds of pieces of legislation are introduced every year in the US Congress to address healthcare reform. This was a shocker to me. Here, take a look at this. Oops, go back. Look, a congressional seating is 2 years. So starting with the 111th Congress, you can see how many bills are proposed, not including resolutions. Every 2 years, there's about 400 of them. It's incredible. And look how many pass, hardly any. And I gotta tell you, they don't cover big stuff. I mean, we had big stuff with the ACA in the 111th Congress, but a lot of these are really small things. Make sure that children with kidney disease get appropriate care and blah, blah, get it covered. You know, they cover particular little Band-Aid items, and we wind up where we are, which is a real mix of a lot of things, and a lot of people not covered, and a lot of people who could have better care not having it. So what is Congress doing about it? Let's talk about that, because this is what we want to learn. So how do you repair the system? Well, I'm an engineer. It kind of depends on what you want to fix. If you do nothing, nothing changes. You'll still be stuck with these 70-some million people who don't have enough insurance, and 200 to 300 people out of every 100,000 dying that don't have to. Okay. If that's okay with you, that's okay. You could have a public option. I think that's been discussed on and off. A public option under the ACA would offer a public insurance trust to compete with private insurance. Okay, that's in discussion in Congress. You could expand Medicare coverage, and you could have a single payer. So let's look into these a little bit more. What's the public option? Well, a public option is a public insurance pool that's established to pay claims for people that choose to enroll, like in the ACA. Public insurance would be paying private providers, but there are lots of various flavors to make this work. Copays, deductibles. Do you cover long-term care with this? Are there any caps on the coverage? Like after you get to $1 million, you got no more insurance? I don't know. Are there caps on copays? After you pay a certain amount, you don't have to pay anymore. So what coverage that is offered could be negotiated. What are the pluses and minuses? Well, it's an interesting experiment in public insurance, although remember, Medicaid and Medicare are also laboratories for public insurance. If you don't have a sufficient population, you might get overloaded with high-risk subscribers, and that would kind of doom it to failure. If you made the public option popular and you wanted people to select it as opposed to other ACA options, you would probably drop the cost. If you drop the cost, you might be increasing your risk and winding up putting in high-risk patients at low cost, and then your insurance trust would be doomed. You'd wind up bankrupt. So you would have to do some clever mathematics to figure out what to do. Including deductibles and copays similar to commercial insurance will limit use. Remember the RAND experiment I talked about before. And the public option doesn't address infrastructure issues like rural health. There have been hundreds of hospitals closing in the last decade in the United States in rural areas. And those people are just out of luck if they're in serious trouble. If you've got to drive a couple of hours to get to a hospital and you're in an emergency situation, you're, as we say in the vernacular, you're in deep trouble. So that is a particular problem. You could expand Medicare. Here's another thing that people are talking about. I think this is in the news. People mention this. Mm-hmm. There are proposals to modify Medicare to add hearing, vision, and dental to standard Medicare. Those are not currently included. You could allow Medicare to negotiate prescription drug prices. Remember, only the VA can do that right now. And remember, Part D made that illegal.
Sweet deal.
Yes, it is. You could lower eligibility for Medicare to 60 or lower. I heard somebody on the news a couple of weeks ago in all of the discussions in Congress say, I'm 55, I want 55. Well, okay, so people are talking about it, but there's no plan in place yet. Medicare, keep in mind, if they just open up Medicare to people, right the way it is right now, there are some issues with it. There is a 20% unlimited copay that comes with Medicare. So if you have $1 million bill and you don't have an Advantage plan or a Gap plan, 200,000 of that is yours. There's no drug coverage unless you get a separate drug policy. And Medicare does offer a replacement with private insurance. And so we'd have to see what expanded Medicare means. Pluses and minuses. Well, older workers might be less likely to stay in a job they hate, or they might retire early to pick up Medicare. It could be lower cost to workers and employers. That might be a benefit. I mean, if I'm 60 and I'm working and I can pick up Medicare instead of having my company insurance, that would be a big benefit to the employer that they wouldn't have to pay. Or maybe they would pay my Medicare, which might be cheaper. Some older persons could be able to benefit from Medicare instead of Medicaid, or they might be able to select Medicare when Medicaid was not available. Remember, in some states, Medicaid is severely limited on an income basis. I mean, the poverty level is you're pretty much homeless. You're homeless adjacent for a lot of states. A drug plan with negotiated prices, vision and dental, that's a plus. But the truth is those are low cost policies, but that would be a plus. Let's advance. So how's it going nationally? What's the legislation that's in place for this stuff? Well, in the House, HR 1976, Medicare for All, was put forward by Pramila Jayapal. It has a 2-year implementation scheme, and it would make Medicare available for everybody, but without copays. And I believe it includes long-term care, as well as dental, vision, and hearing. In the House, there's a bill called SBUHC, State-Based Universal Healthcare, 3775, that was put in place by Ro Khanna from California. It removes a number of the waivers that prevent states from putting together universal healthcare. It's kind of complicated, but if your employer is self-insured and operates in many states, federal law, ERISA, Employee Retirement and Income Security Act, prohibits states from modifying their healthcare plans. It was to protect benefits, but it at the moment prevents much of universal healthcare at the state level. SB 1129 is Senator Bernie Sanders' healthcare bill. It's different than Pramila Jayapal's bill in some issues. It has a 4-year implementation scheme. It has actually an interesting method for payment, and you can see that these things are all covered by taxes. Yale University developed a strategy to pay for it. There's a link, you can go look at it. It's sort of interesting, though, that the Congressional Budget Office about a year ago, last December, did a report that said kind of almost however you put together universal healthcare in the US, you would be saving nationwide $400 billion a year in overhead that doesn't have to be spent, which was shocker for me to see that. Coverage is a matter for universal single payer. No copays or deductibles, cover everybody. Include behavioral, long-term, reproductive, drug, hearing, and dental. Implementation varies from 2 to 4 years. So let's move on. I only have a couple more slides here. Medicare for all, single payer plus. Overall lower cost, more coverage for more people. It's easier to the pluses in single payer. It's generally lower cost for almost everybody. It is easier to identify and prosecute fraud. I don't want to spend too much time on this, but Medicare has about a 6% fraud rate. Commercial insurance has 10 or more %, some of them going as high as 15. Fraud in the commercial world is not generally prosecuted. In the Medicare world, it is prosecuted because it's federal. It's a federal crime. I will point out that Taiwan, when they implemented their system, they discovered 8% fraud and they wiped it out and dropped their healthcare bill as a country. Copays and deductibles, there aren't any. I mentioned this already. Vision, dental, long-term care. It also supports capitalization of rural healthcare in hospitals. It puts back the funding to rural medicine so that people will be able to get care. I actually like this in the Pramila Jayapal bill. It was kind of clever that she put this in. It provides an off-ramp for displaced workers and additional unemployment, which was good, and training. It simplifies billing. Remember, we had 952 different insurance companies. Not all the billings are the same, and we can talk another day about upcoding that's done in the insurance world. Generally, it increases physician revenue. I was shocked to see this. PNHP has a research paper on this. Part of the problem is that doctors, when they have to deal with so many different insurance coding schemes, they wind up having to hire extra people to do it. And about 20% of insurance bills are rejected. This is shocking, 20% rejected. And that means a lot of times people pick up the cost themselves. However, if you call the insurer and say, hey, wait a minute, you're wrong, that rejection gets overturned about 90% of the time.
But that costs you time.
It takes time and money. And actually, well, we can talk about it a different day. Okay, let's move on. Benefits to a single system, common database of healthcare. This is a big public health issue. I mentioned this about Taiwan and their fraud identification and their low COVID deaths. That's a good thing. It makes people more likely to this was another big one. This came up this year. It makes people likely to participate in advanced early testing. Actually, anytime there's universal care, it doesn't matter what the system that puts in place. As long as people are guaranteed that they're going to be taken care of, they're willing to participate in studies that help make healthcare better for everybody. There's a company called Grail. They put together a Galleri test, and it uses a blood mechanism to identify 50 cancers early, like early prostate, I think, and breast cancer and stuff like that. So you can find out early on, before there are any symptoms, that I've got cancer and I can get it treated like early, and early detection and treatment is the key. They were unable to get this test going in the United States because people were scared that if they were found to have cancer, that's a pre-existing condition, and at some point they might lose insurance. In England, however, they found 150,000 people almost immediately ready to do it because they don't lose their health care. So there's a benefit to having health care. Medicare for all minuses. Well, there is a problem. Structure of premiums changes from an expense to a tax. Well, if it's a tax, that will change accounting. And so someone has to figure out how that works. Insurance company products will likely change. Insurance companies scream long and loud that they'll go bankrupt and they'll take the country bankrupt. However, when they did it in Switzerland after a 10-year investigation, the insurance companies found that they made more money there than they ever made before. Remember, they had the private companies selling the nonprofit insurance. They made more money than ever before because they bundled together home policies, auto policies, life policies, optional healthcare policies, and mandatory healthcare policies. They never sold that much insurance ever, and they made a lot more money. Cost reimbursements will change. Many facilities will have overhead provided, and so the fee structure model changes. Reduced billing complexity and claim denial armies get reduced, and so the labor required to obtain payment drops. That's those people that will be put out of work. Senate Bill 5204 in the state of Washington. Let's talk about that very briefly. Senator Hasegawa put forth a bill called create the whole Washington Health Trust. It would have been universal health care in the state of Washington. It did not pass. Instead, the state of Washington passed Senate Bill 5399, the creation of the Universal Healthcare Commission. It was signed by the governor, and I think just a couple of weeks ago, the full commission has been nominated. So they have about 8 people from government, and they have 8 citizen commissioners, and they're going to work on putting a plan together for that for the state of Washington by 2026. So that's kind of interesting. I will point out, I am obliged to point out to you, remember that this is educational, and I'm presenting a lot of different techniques. The league position on state-based universal health care is not positive. They are opposed to a strictly private market-based model of financing the healthcare system. And the league is, right, so that's like private insurance everywhere. They're also opposed to the administration of the healthcare system solely by the private sector or the states, right? So that's universal coverage for the states. Okay, do I have to do questions?
No. Do you
okay.
want to?
Well, I've included, let me just do this really quickly and then I'll answer questions. I've included in the package, which you have, the NAACP and LULAC came out in support of Medicare for all. That was the choice that they made. And a bunch of unions did as well. And about in 2017, HR 676 was another Medicare reform, Medicare for Everybody bill came out. And there were about 600 unions nationwide that supported that. And just to let you know where representatives stand on healthcare in general, we have 3 in Washington, Jayapal Smith, oh no, 2, Jayapal and Smith support Medicare for all. The other 8 of 10 have not taken a stand on it. and as far as I know, have not taken a stand on expanded Medicare for all or on the public option yet. And our senators currently do not support a single payer system. So look, we've talked a lot about different systems. We talked about expanding Medicare. We talked about a public option. We talked about single payer. We talked about we have a problem in this country, it looks like. I think so. Whichever system you think might work, if you're interested in this, you should let your representative know. Tell them, I like this, or I don't like that, or I want you to do this, or I don't want you to do that. But your voice really matters to them, and they need to hear. Because if they don't hear from their constituents, and if they hear the voice of the people to figure out what to do. And I think that brings us to the end of the presentation. There are references here for you to learn about different healthcare schemes and how to pay for them. You can flip through those at your leisure.
Ask Heather to do the chat.
Heather, are there any questions?
Yes, there are 3 different questions.
Okay.
The first one is, Irene says, I read on a site this week that CMS Medicare does not provide oversight of the Part C insurance companies. I wonder who provides oversight for the quality of care from these health insurance companies?
So since they're insurance companies, the answer is the state in which they do business. Every insurance company is licensed to do business in a state, and they are responsible to the whoever heads up the board of insurance in the state. However, I don't think that they have to provide the same quality metrics that Medicare has to provide. But I will take an action to go and check to see what CMS does get from private insurers, if anything. I'll go look.
And then Glenna asked, is it correct that the Social Security funds have been diverted for non-Social Security, non-SSN projects, including Medicare-Medicaid?
I have no knowledge of that. In years gone by, it was not an uncommon thing at the federal level. They didn't divert funds because that would be illegal. I think what they did was that certain buckets of money were loaned from one agency or trust to another to be paid back. I don't think they divert them, but I can look that up.
And then Irene asks or states, I am seeing a CMS civil money penalty for PACE, P-A-C-E, from 2019. So they must be doing some audits of quality of care for parts of the CFR, and then parentheses, which says not related to prescription drug coverage. Sponsors, in quotation, are required to provide oversight. Sounds like the health plans monitor themselves and report to CMS.
Could be. What is the right word? I confess ignorance on this point, but I'm delighted to talk to Irene. I see that Deanne would like the PowerPoint. I think, Deanne, I will certainly send it to you, but I think for people that registered, I think a PDF of this version went out. Absolutely.
Hopefully you got it, Deanne.
So the bottom line takeaway from this is there are lots of people thinking about lots of things to do with health insurance. We have a lot of options. Some people are of the opinion that it's just fine. Thank you. It's just fine the way it is. And for you, it might be, but I've given you some questions to go find out how fine it is for you. If you think it needs change, there are a lot of different options for change. There are state options for change. There are national options for change. You should have a discussion with your representatives and with your friends and family, and talk to your representatives. Let them know, really let them know what you think. Because I gotta tell you, healthcare is not on everybody's radar. I mean, I have discussions all the time with people in my congressional representative's office, and she has been an advocate for any number of very specific healthcare related issues and an opponent of many others. And it's a matter of talking to them over and over and over again to let them know how you feel. That's what they really need to know. So, and that's kind of the goal of the League of Women Voters, to get people involved and let your representatives know how you feel, because that's the point, is they represent. Okay, any other questions? If you didn't get the PDF, check your spam email folder.
Okay, Amy says that.
Thank you, Amy. Okay, anything else?
You can unmute yourself and
I'd
just
be
ask
just
a question
unmute
if you
yourself
want
and
to.
ask a question. There aren't that many of us.
What people are thinking, while people are thinking of a question, I'm going to put in the chat the website, the FERL website, to subscribe to our email newsletter. So you can, if you don't already, you'll get a monthly newsletter that in your email box that will tell you what's coming up, including programs like this one.
I have a question. Can I give somebody continuing education credits for this?
I think that depends
Just kidding.
on who they're turning those credits into. So it looks like we're wrapping things up. I want to give a big thanks to Alan and Volker and Heather for spending time with us on this really important topic. So thank you again. We always appreciate the League doing programs for us. You give us great information. So it was great to see you again, Alan. And we'll say good night. Have a lovely evening. Have a great week. Happy holidays coming up. And look for more League of Women Voter programs in cooperation with the library in the future.